and listen in on some dental-specific lectures. Today's first topic is from Hamza Surti. He has his bachelor's in mechanical engineering and has done his graduate studies in computer science at Georgia Tech. He was an early engineer at Pearl AI and VP of product and engineering at Backpack. And currently he's the CTO of Stratos, right, Hamza? And it's an AI and space application. So we want to welcome him in. He's going to talk to us about dental AI and radiography and how it works and how his experience was at Pearl.
Cool. No, I don't need it. You can hear me, right? Okay, cool. Okay, this is on. Yeah, like Mufadlabai said, I'm not a dentist, so I'm going to be throwing around a couple dental terms here and there. Feel free to laugh at me. Just don't do it in front of my face. So the point of this talk is to kind of demystify AI a little bit, and it's I think I heard a conversation that during lunch that somebody was like, AI is just a buzzword at this point. So my goal here.
That was your father-in-law.
Yeah. I didn't want to call you out about it, but I just wanted to try and demystify what AI is, how it works, and how it works in dental radiography a little bit. So just start off with a little bit of a poll. How many people here use AI in their dental practice? One, a couple. How many have kind of tried it or seen it or been marketed it? Okay. And then I just like, if you can call things out, what are your biggest kind of fears? How much do you know? Especially the couple of people that have seen it and been marketed it but haven't tried it yet. What's the fear? Cost? Okay, cool. Anybody else? Okay. It's fine. Wrong way. Okay, so with that in mind, the kind of goal of what I want to go through is I'll spend most of my time trying to basically explain how AI works a little bit in general, and then a little bit deeper on how AI works in radiography and specifically in dental radiography. And I'll kind of go through a little bit of kind of how things work behind the scenes. So you can understand when you get an AI detection in front of your screen at the end of the day, what that actually means, and explain that it's not just a black box that does a bunch of magic, right? And then we'll go into a little bit of measuring performance. And then at Pearl, I was part of like the team that got FDA approval for the first time for AI. And so I want to walk you through a little bit of what the clinical trial looked like, how we set it up, what the FDA looks for, and kind of why it got cleared. And then I'll speculate a little bit about kind of what the future will look like. But kind of I want that to be a little bit open. If you have questions, please stop me. We're a very small group here, so I want to make this as useful as possible. And so sometimes I might go very technical, tech jargony. If I go too technical, tech jargony, please stop me and ask a question. What does that term mean? You keep using it, et cetera, et cetera. The point of it is just to make this as accessible to you as possible. Okay, so what is AI? This is what everybody gets marketed. It's this perfect thing that it can imitate human intelligence, that it can do all this stuff. But really under the hood, it's a whole lot of different techniques that effectively just use math and statistics to get you an answer to some question that you ask. And so the most common thing that everybody knows is ChatGPT. ChatGPT uses a couple of these techniques, but certainly not all of them. And so under the term AI, everybody just like tacks on AI, and they're not technically wrong, but you can't equate one thing to another always. A lot of the techniques that get used behind the scenes are specialized towards certain applications. And so what we'll focus on is radiographs and specifically image generation. not image generation, but image like pattern recognition, which is what I did at Pearl. So just kind of contrast the two, just in terms of like you don't need to know what either of these diagrams mean. It doesn't matter. But fundamentally, the way ChatGPT works is on my right there, on your left, and the way that detection of like caries, for example, in a radiograph from Pearl works is right here. So they're kind of two fundamentally different ways to approach a machine learning, an AI problem, and they're kind of two fundamentally different things. That's kind of the important point to note. And so I'll focus basically all my time on how Pearl, because I work there, and other kind of dental radiograph companies like Overjet or Denti or whatever, how their AI works under the hood. And I'll focus a little less on ChatGPT. If you want to know about that, we can talk about it at the end. All right, so let me go back up actually. So what this actually is something called supervised learning. And effectively means that you get a bunch of radiographs as like, pretend I'm Pearl or whatever dental AI training company. I go and try to get a diverse set of radiographs from a bunch of different places. And then I pay a bunch of dentists to tell me and to annotate those images and say, hey, this is caries, this is calculus, this is a periapical radiolucency, et cetera, et cetera. And so basically Pearl, when it was started, paid dentists to annotate thousands and thousands and thousands of images. Right? So that was the first step in order to train any model. And then once you get a bunch of images that are trained, then you do some quality control on them, right? You make sure that there aren't bad actors in there, that they're not messing up the data test. You can do that algorithmically and a little bit of spot checking. We had dentists on staff that did that. And then you train a model, and then you basically allow it to predict on new images. And so this process happens in the beginning, right, when Pearl first started, but it continually happens over and over again. It continues to happen, but an important thing to note is that when you send a radiograph to Pearl, it doesn't automatically make the AI better. Like the notion that AI will automatically make itself better is mostly a misnomer, especially for applications like this. The radiograph goes, it gets, if they have permission to use it for training, then it'll get annotated. And then that annotation will help train a model, and usually months later, that will make it into the model that gets that you use on a day-to-day basis. And so each image that comes in and that it gets separated into 3 sets. And I'm going into a little bit of detail here, but it's just kind of to make the broader point. One set, about 80% of them usually are training images. The next 10% is something called like effectively test images. So like the people who are training these models day to day, the engineers, those are for them to kind of help them understand how the model that they're training daily is doing. And then the last 10% is used for evaluation. And that 10% that's used for evaluation is generally put completely to the side, and that's the final test before a model can be put in front of people. And so it's kind of, nobody can touch them, nobody can look at them, they're just to evaluate how your model is doing. That's why you can kind of keep track over time, and you kind of, as you train more and more models, you make sure that the model doesn't get worse over time, so you train it, you test it against your eval set. Cool. So I want to talk a little bit more. I keep saying training, training, training. What does that actually mean? And so that takes a couple of steps. And so these models they're called neural networks. And neural networks at a very, very, very basic level kind of tries to imitate what the neurons in your brain do. They're significantly worse than the neurons in your brain and significantly more limited, but at a very basic level, that's what they do. And so when you go to start training a model, the model starts out very dumb, very dumb. First, you basically have to train it to recognize like this pixel is light and this pixel is dark. Then once it gets past that step, there's a couple of light pixels here in a curve. This and next to these darker pixels, that means there's probably some sort of detection there. There's probably some sort of object there or something. The next one after that is like, okay, if you're in a clinical setting, these set of pixels probably means that there's a caries or something like that. And then the last step is like, okay, once you do all that, once you train, and then once you put a new image in there, what's the confidence that these set of pixels is the thing that you've trained it on? So every time a model predicts something, it'll come with a confidence score, and that confidence score, I'll explain how it's used in practicality later, but it's very important to what you eventually end up seeing. And so kind of just to explain a little bit more visually what that is, this is facial recognition. And so when a neural network is learning how to do facial recognition, it'll just start with like basic lines and shapes. And then as further and further down the neural net it goes, you can start to make out a few features. Maybe this is a mouth, maybe this is an eye, and then you kind of get closer to what looks like a face. And so that's why neural nets need so much time to train, so many images. What's interesting about images, we won't go too far into this, but because there's so many pixels, the neural networks are trained on like pixel level almost, rather than images. And so I can go down a rabbit hole there, I'll stop there, but that's kind of effectively how they learn. Okay, so what Perl uses and what all the dental AI companies use is something called a convolutional neural network. And so the way it sees, is it basically takes a sliding window of a photo and basically goes over the entire image. And so in this photo here, if you're looking at it, obviously there's huge caries here, right? And so you can see, okay, this is a couple teeth, and there's a huge caries here. Like you have all of the context when you're looking at this image, right? But when the neural network sees it, it sees this tiny little zoomed in. This is probably even too much, honestly, but it's for just to explain it. It just sees this sliding window, right? And it goes through the entire image and it sees that photo. And so this is a really obvious example here, right? But where that becomes like a very good example of where that becomes problematic is like when you're dealing with cone cuts. And so this is an image of a cone cut. If the AI is here, how does the AI distinguish that this isn't a metal filling, right? It can't. And so when we first started, we just had the basic AI. We were just like showing people, look what the AI can do. Oftentimes it would throw a bunch of detections here that said, you have a bunch of metal fillings right here. And we just get laughed out of the room by dentists, right? Because it's obviously very clearly not. But the neural network has no idea of context. And that's a fundamental limitation of this specific model, right? And I talked about ChatGPT a little bit. What's interesting about those models is that they have a lot more context. We can talk a little bit more about how that might evolve in the future. But at current state of the art for dental radiographs, they're trained like this, and they have this fundamental limitation. So if you are a company or whoever trying to make dental AI work, what do you do? So sorry, before I go there, despite that, they're very, very good at noticing slight differences in pixels because they're trained at such a small pixel level. They can often notice differences in pixels that humans can't. But if you try to tell them to do multiple things, they kind of mess up, right? So if I tell it to the same model to tell me where there's caries and where there's calculus, like it's going to confused, or radiolucency or something like that, right? It'll get confused and it might start throwing a lot of false positives. And so what you do is you say, okay, if that's one of the limitations, let me train a whole bunch of models, right? We want an expert just in caries. we want an expert just in calculus. We want an expert to tell me what type of image it is, because certain models are better at training on bite wings versus panos, or whatever it may be, right? So you want to effectively break down the problem to the smallest chunks as possible. And then you also, arguably in my opinion, the most important part of it is you have a model that's really, really good at breaking down the anatomy of a tooth into parts. That way that if you get a bunch of detections on the cone cut, you know that this isn't on a tooth, we can just throw them out. And so what that looks like in practice is when you take a radiograph and send that to some AI company, it'll go in. First thing that'll happen is it'll classify what kind of image it is, right? Is it a bite wing? Is it a pano, right? And based on if it's a bite wing or a pano, it'll go to different models, because certain models are very good at detecting caries in panos, and certain models are very good at detecting caries in bite wings, because they're just fundamentally different kinds of images. Then the next place it'll often go is, and they labeled it tooth anatomist, but basically it just like breaks out the parts of the tooth. This is dentin, this is pulp, et cetera, et cetera. And then it'll go and send the same image to all of the different pathology detectors that they offer or whatever. All right, so these are restorations, this is caries, this is calculus, et cetera, and then it'll all come together. And I should have put up like an image of a brain here, but basically like all of that comes together, and basically you have a bunch of business logic. And so that's kind of what we worked on. We basically like had dentists on staff, and we extracted their brain and made them into rules that said, hey, if it's this kind of image on this tooth or this type of tooth, and it's detecting caries here, is it actually a caries? What's the percent? How likely is it to be caries versus something else versus something else versus something else? So it takes all of the neural network's predictions and confidence scores, which I'll get into a little bit later, and you combine it, and then ultimately you get so a couple examples of this that aren't that great, but like, yeah, if a caries isn't on a tooth, then obviously it's not a caries. If there's calculus inside the pulp, it's probably not calculus, et cetera, right? So you can kind of break everything down into the smallest pieces and kind of just keep what's remaining. And so kind of I walked through this already, but basically like image goes, gets sent to multiple pipelines, pixel by pixel analysis, confidence scores for each of the regions, and along with that, like the brain kind of concept that I put earlier, the confidence thresholds matter, right? Each detection will come with a confidence score, like I mentioned, and then in the initial version of the product that we were putting out, had a slider that, actually this is available in the EU but not in the US, had a slider that said, hey, I want to see all of the pathologies that are detected with 30% confidence or more, 50% confidence or more, 75% confidence or more, and you could toggle that. But in order to get it cleared by the FDA here, we had to do clinical trials for every single percent that we offered it in the slider.
What percentage is your model currently in the US?
I think it's the tops. I think it's 75 plus. I think it's been a couple years, so I've forgotten. But yeah, in order to get it approved by the FDA, we had to run a clinical trial at every single confidence level, which was.
Clinicians can set it up wherever they want, or is it preset?
It's preset because I'll get into it, but that's what's been cleared by the FDA. Okay. In the EU, surprisingly, it's a little bit more open, and so we were. EU and the rest of the world, basically that slider exists. And I'll show you in the picture here. This is what the slider is. So low, medium, high. And effectively you can kind of toggle with that, like the percentage that you want. And so you put all the stuff that I've been talking about together, and this is what Second Opinion, which is Pearl's product, shows you.
The confidence number is way into the cutoff, right? Where you say this is so much like you draw the ABC curve.
Yes. Yeah, that's exactly what happens.
That's
But to simplified, it means at this % confidence. Like that's what the neural network does, right? When it predicts, when it tells you its confidence, it's basically calculating the area and kind of under the curve.
so
Kind of.
at different cutoffs, then that's how you get your rates. But do you know what the sensitivity specificity was in that?
That's what I'm going to get to next. How do you evaluate? And so you can have a model that'll throw, that'll basically draw boxes all around the screen and say, hey, I caught everything, right? It caught all the true positives, great. And then, but there's a lot of false positives, and false positives, just kind of back up a little bit, is when it draws a box on a caries that, for example, doesn't exist. Our false negatives is when there is a caries, but the AI didn't detect it. And then lastly, true negative, there wasn't something there, and the AI didn't do nothing, just like the baseline, right? And so what we were talking about, right, is the balance between recall, which is what percentage of all actual lesions in this case did the AI catch, right? So like I said, you could have something that just draws a bunch of boxes and it catches 100%. But obviously you don't want just a box drawer as a product. And so then the flip side of that is precision, which is how, when it does draw a box, how often is something actually there, right? And so like you do this every day as a dentist when you read a radiograph, right? You make a call on like, oh, I'm pretty sure there's something there, versus maybe it's not, right? But basically what we have to do, or we had to do, is quantify that, one, and then justify to the FDA that where we're drawing our lines is good enough such that it doesn't make the dentist worse. It actually does help. And so with that, let's get into the clinical trial a little bit. And so we'll go into that a little bit right now. Yeah.
How important is the quality of the radiograph in a normal general dental practice?
It's exceptionally important. So much so that I've since left Pearl. So much so that one of the products that they've since put out is an AI that tells you how well you've taken your radiograph. Because at a certain, like if it's just a bad radiograph, then you're just going to get a bunch of noise.
The problem is the human element, right? The patient and the dental assistant.
Absolutely.
I know I have it too. It tells them that it's not exposed, it's not green, but still they'll say it was hurting. So that's the challenge you all face.
So I think exposure and is a little bit less important because the way the neural network works is it'll take the difference between the pixels. So that's exposure is really bad for human eyes, right? But for the machine, it's a little bit less important. Now, like cone cuts are just like a poorly taken like angle, or that's a lot harder because it's been trained on. Now I think they've been trained on bad images, good images, and everything just to kind of cover those cases. But the vast majority of the images that it's been trained on have been pretty good radiographs. And so that hence the entire product line that says you've taken a bad radiograph, you've taken a good radiograph.
I think it's important also the resolution of the radiograph.
Yeah. Resolution is important, but part of the data gathering that we did in the beginning was to gather poor quality radiographs. Because when we started, it was 2019, and a lot of people didn't have high quality equipment then. And so just the nature of the equipment meant that the AI had to be good on resolution, poor resolution radiographs, right? So that's a little bit baked in. Maybe that's changing and it's kind of biasing towards good quality ones now. I'm not sure. Okay. Sorry? We did have scanned radiographs. It did work on scanned radiographs, but like it's just not going to be as accurate. It was more like I remember people So part of my job was to, this was very early days, was to go in and help people kind of set things up. Now it's kind of been streamlined and it's really easy to get set up. But in the early days, like I would remote onto their computers, help extract the radiographs and do all that stuff. And some people just had scans. And initial data set, there was no training on the scans. What we saw was that it did pretty good. I don't have numbers to quantify that, but so it worked. It just can't be guaranteed in the same way.
Well, I mean, for example, let's say you went to another clinic and they sent you the radiograph. Now change that.
Yeah, so that should be fine. At least we tried to maximize the image quality types or image quality types. Like try to have as diverse as we can as a data set. There was just like by the nature of how you're collecting things, you get more of some and less of the other. Any more questions generally? That's more fun for me, honestly.
So during the evaluation of the model, you mentioned you evaluate basically based on the test data set, right? And then you get like how well the model is performing on that particular data set.
Sure.
So when it's actually in production, and the model is now classifying the radiographs, so how do you evaluate during the production itself? Do you have the actual dentist then also like comparing against the model performance to know how well the model is actually doing at that point of time?
It's a good question, and did everybody hear? The question, maybe I misunderstood, but I don't think that was, the question was when it's actually running in production, did you have dentists go in and evaluate as it was running in production? And I'll give you behind the scenes, very early days, when the models were still okay. This is pre-clinical trial. I built a tool that as soon as a radiograph was sent to Pearl, it got popped up to a dentist, and the image detection would happen by the AI, and it popped up in front of an actual dentist, and the dentist would double check the image, and if there was like false positive or something, they would just like X out of it, X out of it, X out of those images, and then that happens a lot more rarely these days, but it will happen because you want just a general quality check images as they come in, that things aren't completely off the rails, or there's some subset of images, or like maybe a specific practice takes images in a certain way that the model is not ready for. So that does happen. It's called human in the loop, right? So that does happen. Early days, it was a lot more common. Yeah.
So you mentioned that if it sees a lesion and it's not part of the tool, it's like a concut. What about lesions that are not odontogenic or not tooth related?
So it depends on if when I worked there, we didn't support lesions that weren't tooth related. I know that a lot of that capability has grown since, and so whatever the product will say, like, hey, this is caries, this is whatever. I don't know enough about non-tooth-based lesions, but if it's generally marketed as we can detect this, that means it's cleared by the FDA that they can go and detect that.
I can answer that question because I've been using Perlay for about a year now. Basically, whatever is diagnostic off of a bite wing, it can diagnose that. So, for example, if you see an OKC remnant on a bite wing and you need to take a panel for further evaluation, it won't be able to diagnose any of those non-odontogenic lesions. So, like
diagnose panel?
no, it's just PAs at the end, regulus. So caries, calculus, periodontal bone loss, the amount of the penetration of caries into dentin, into the pulp, it can be very clear about that percentage, or if it's into the dentin. Periodontal lesion? Periodontal lesion is also part of it. What about like hypersematosis? No, hypersematosis. No, it doesn't show that. It doesn't. It's not very good at diagnosing that.
So, Papa, what did you say it will not diagnose? I
Like an
didn't catch
OKC,
that.
an OKC, for example. What's OKC? Oh, okay. Like a remnant of that. It's not a cavity. It doesn't matter. Just gonna refer. I didn't know anything but the acronyms, so I just said that.
So, dental
guaranteed. I'm surprised that they don't do panos now, because I know they did run a clinical trial for panos.
Even CT.
Oh, yeah.
I'm sure there is. It just gets more complex.
That-
Let me put it simply. I want to do as less work as possible. Can my assistant do it, and then I just don't have to be there?
Yes.
Perfect. Okay, so I'll take two.
Cool, great. Okay, any more? I'll go into kind of how the FDA trial was set up too right now. So effectively, the FDA trial looks to do three things. Validate that the AI can actually find whatever lesion. So you have to run a clinical trial for each type of pathology that you say you want to detect. So for caries, you run one clinical trial. For periapical, like I don't know what the term periapical radiolucency is what we called it. Yeah, sure. Parl, cool. I'm gonna forget that. Parl, okay. For calculus, there's a separate one. So it was all run under the same like full clinical trial when we ran it, but they're evaluated separately. And so each of them has to pass statistically on its own in order to be allowed to be shown in front of patients. And so the difference is preclinical trial, we could show all of the AI detections, whatever we wanted, but it had to be not in front of patient, like a patient couldn't see it. Post-clinical trial, it can be shown chairside in front of a patient. That's the fundamental thing that the clinical trial allows each of these companies to do. So if it's chairside, that means it should be FDA approved. And so AI has to be able to detect whatever pathology. It has to show to improve or stay the same in terms of dentists being able to detect whatever it is. So it can't make you worse. Well, it should make you better, and it can't make you worse. Those are effectively the three things. There's a lot of words here, but the first thing is how well can it spot pathologies? Does it improve? Does it not? So the data set, basically you have to do this over a large enough data set, right? And so what we did was we had about 2,000 images, and each of those images was sent to an expert to mark up, because you can't have the ground truth of whatever of the clinical trial being AI itself. So you need human experts to say, hey, there's actually this here. And those experts, I know for a fact, have trained multiple people in this room. So I like to think that they are decent. However, an interesting tidbit that we found, and honestly was the hardest part of the clinical trial, there was 4 experts, and they all had different, everything was just different. And so the joke, I don't know if you guys will appreciate it, but I'm just going to say it anyways. The joke that I always like to make is the number one thing I learned when I worked at Pro was that Colgate ad that said 4 out of 5 dentists agree on something is the most nonsensical thing, because dentists can't agree on anything. And so effectively, the Colgate ad was 4 out of 5 dentists agree that you should use Colgate or whatever. Recommended, yeah.
Well, so you said you built this tool when you were doing the checking, and then they would go and say yes or no.
Yeah.
But that was just the one dentist. Did you
So-
ever try doing
So the tool that I built was,
comparables between 2 dentists?
yeah, so for the clinical trial, yes. So I'll break things up a little bit. So for the clinical trial, the way it was structured, 3 out of the 4 experts had to agree that this is a lesion. That's kind of where it ended. For day-to-day activity, the purpose of that was not to, it was to just like get rid of the completely nonsensical stuff. And so this was when I built it at least, it was before we had that tooth parts thing that was before all that. So then you did have random stuff in a cone cut, right? And you had all this weird stuff. So we were just like, what's the fastest way that we can make it so this isn't just bad? And this is preclinical trial as well, right? And so that's what that general tool was. It was to catch the and that was instructions given to those dentists. If it's kind of on the edge, you don't get to make the determination. If it's just clearly like bad, then you can do it. But yeah, for the clinical trial, 3 out of 4 dentists, 3 out of the 4 experts had to agree that this was something for it to be considered whatever. And then the way the rest of the clinical trial was structured was we had 25 readers, they're called, which were 25 dentists that kind of worked in practices around the country. And they had to basically draw or just effectively detect there's caries here, there's calculus here, there's periapical radiolucency, pearl there, and there's we called it margin discrepancy at the time, and then later we learned that that was a poor way of calling it, but whatever, I'm just going to call it margin discrepancy. And so they had to go and find all of that on all 2,000 radiographs. And in order to make it so that, so the way it was broken up was they did 1,000 radiographs with, it was called Second Opinion Pro software, with Second Opinion, 1,000 without. And between the two, so basically, yeah, we had 25, half of them did with it, half of them did it without it, and then we waited 4 weeks, and then you switched. And so all of them did every single radiograph, and we had to prove with statistical significance that they were doing better and not getting worse on certain things. And so ultimately what we got was, for caries, overall, it was really small. I don't think you care too much about the exact numbers. For caries, there was like a marginal improvement, like a couple percentage points. It was statistically significant. My hypothesis is that because you guys are looking for caries all day, every day, you guys are pretty good at it already. And the rest of them, margin discrepancy, calculus, I don't think you care that much in a radiograph. So you do? Okay. Well, calculus went up, but the number one, I don't know. But the number one thing that went up, 100% of readers got better at finding periapical radiolucency through the clinical trial. And so, but point being, each of these effectively went through a separate kind of statistical significance calculation, and each of them had to be approved separately. And each of them showed that it met all 3 benchmarks.
And none of them got worse?
None of them got worse. I used to have some numbers here, but they were really complicated. I had this FDA trial study is publicly available on the internet, so you can just go look it up before you choose to buy or not buy or cancel in your case. And okay, so that effectively you prove that all of those things were met.
Go back a slide. 100%, that's insane.
On periapical, yeah. It was like everybody got better.
I can attest to that too as well. Periapical radiolucency, especially difficult ones to find when you're determining where pathology is coming from pain in patients.
Yeah.
It's extremely valuable. I think we probably use that feature
More than
one of the most undervalued.
They all improve their sensitivity. It's not like.
No, I understand, yeah. But 100% is like.
Yeah, they all.
Everybody improved, yeah. This is just a slide, effectively to round all of it out, right? It's there to help you. I think, one, it can't replace you just because of the way they've been approved, right? Like fundamentally, at a legal level, they just can't replace you because it's been cleared to be chairside and helpful. Sorry, man.
If I can't replace me, I want my assistant to do it.
I mean, it can, yeah. All good. There are limitations, right? We went through that with the cone cut discussion. And while like we have all these methods to make it work really well most of the time, there's still going to be maybe you can attest some really random things that it finds that you're like, this is a bunch of nonsense. Integration skills, that's honestly AI made the last two because I wanted 4 because it looked good. But where we found, and I don't know Huzaifa, if you can attest to this, what we found when we got feedback for the first few people that were using it, improving your ability to catch things, it maybe improved a little bit or it didn't improve. But the number one place that we got feedback consistently was it helps me explain what's going on to my patients. And they trust me more because the AI says it. And so I think Pearl still has it. I don't know if it does. But we added a feature that if like, Pearl's not going to catch it all the time. If Pearl didn't catch it, you can just draw a box saying that it's there. It just helps you explain things a little bit.
Do you guys ever do study on acceptance with or without AI? What I like about it is just the color, right?
Yeah.
It makes it easy for patients to see the different color things. But do you see like right now, if you show a regular doctor patient, they go, oh my God, it looks like toes. Yeah. Right?
Yeah.
Now when you look at this, now it makes it sexy, right?
Yeah, it does. So when I was there, they didn't. I'm pretty sure since I've left, they have. Because honestly, that's the number one selling point for a lot of dentists. So I'm sure there's plenty of marketing material like white papers that they've published. I'm not sure, 100% sure, but I'm pretty sure that you can go and look at that says that acceptance is coming.
Insurance benefits also, submitting for insurance like claims.
Well, did they give more preference to this?
Yeah, the Overjet, which is their competitor, actually has an integration for insurance submission.
Yeah.
So you submit it with that, and the insurance actually will accept Overjet. Pearl is their competitor, but with that, the insurance companies actually use Overjet. That's how they deny all your claims. So if Overjet says yes, then it's just automatically approved. So Pearl can be used similar.
Yeah, that's
Pearl doesn't have that, right? Overjet is more expensive.
Yeah, it's more expensive.
Yeah.
But that's the benefit of the real feature.
One other thing that I think Hamza didn't mention, but one thing feature I really liked, and I don't know how useful this is in caries control, but one thing it also gives us a percentage penetration into enamel and to dentin as well. Sometimes if you see enamel limited lesions and are unsure whether they're into the dentin or not, visually, Pearl, the second opinion gives you a little bit of an insight on what it believes is penetrating into dentin or not. And so sometimes it says 100% penetration dentin and like into or to enamel and dentin, you can decide whether to treat or not treat those.
What do you find accuracy-wise? Is it pretty?
I think it's very good.
Okay.
It's not perfect.
But
I think on a day-to-day usage of it and putting it into your routine, it'll save you time. It'll help you explain to patients, and it'll help you catch things that you may not catch otherwise. Because there's countless number of patients that come by that before we had the software, and now that we do have the software, we're going back to old X-rays and picking up things occasionally that were not found on the first exam.
You have a slide where it compared the color with the regular X-ray?
I don't. I don't have access to all the stuff I used to. These are just whatever I could find on Google, honestly. So yeah.
So what I can say though is that the color of the teeth where it shows the enamel, dentin, and pulp, that's a separate on-off toggle. You can turn that off and just put pathology on, where it'll recognize the calculus in the green box, the caries in a pink color.
Yeah.
And I think there's a pair of
So the percentage that Huzaifa was talking about, so this is percent into enamel and this is percent into dentin. That's what that is.
Right now in the Pearl, they have the PDL on there.
They do not have a PDL. They do have calculus, and they have millimeters from the CEJ to that. They have.
And Overjet has that. So
Yeah.
Do you know any comparison between Overjet and Pearl? Or no?
Go Pearl. I don't know any comparison. I know both companies deeply hate each other.
Yeah.
One. But two, I don't know if this is helpful, but it's just like a little bit of history that kind of colors how they've approached the market, and so maybe that'll help somehow. Overjet, when they started, they hired a bunch of people from insurance companies, and they attacked the insurance market.
Yeah.
That's where they started. Pearl started as effectively this second opinion was the main thing that we were aiming to launch, and then we launched other stuff along the way. And Pearl has a insurance product as well. It's just like not as old as, Overjet's, that's the first thing they ever did.
Yeah,
right?
so I listened to Overjet, like, did the marketing thing with me, and one of the things that they kind of advertise that they're stronger in is that because they have an in with insurance companies, they're able to give you data back on patient information more clearly and readily available. So like their benefits, what their coverage is, analysis on those things, whereas Pearl doesn't have that inward door with them, right?
Yeah.
Or that connection.
Yeah.
Pricing.
That's why it's,
Yeah.
the bone loss, you know how sometimes more in one area, is it able to detect that, the difference in darkness on the bone?
That's what these little, I don't know if you can see them really well, maybe. Here, these little bars here, that's what they are.
It's pretty good about that. If it's like a two-dimensional image and there's buccal and lingual bone loss is different, it'll recognize the bone loss.
I came a little late, so I
Yeah.
didn't catch, like, do you represent Pearl or you left Pearl?
I worked there early days when they kind of first started, and so I was part of, I built a lot of the software. This thing, the first version of it I made, the software that ran the clinical trial I made.
And now you have your own company.
Yeah, now I've moved on. I left in 2022. Because everybody asked me to talk about this, so I'm here talking about it.
You don't have your own dental AI.
No. I have.
You're just kind of talking about
His experience.
his
Yeah.
experience with Pearl.
Yeah.
Okay, gotcha.
Yeah.
Because that was paid by Pearl.
Yeah.
Sadly, I
Yeah.
So the 25 people who actually did the data analysis, were they dentists or were they?
They were dentists.
Not radiologists.
No, I don't remember, but I'm pretty sure they were dentists.
Because you're comparing a data set, you take your data set and you're doing machine learning. This is essentially machine learning, right?
Yes.
So there's black and then there's white, and then there's 256 shades of gray.
Sure.
Those 256 shades of gray are open to interpretation.
Yes.
So if the data set is flawed because we didn't recognize a particular shade of gray, then the essential model is flawed too.
So the experts were radiologists and people who, you said the readers, which were the 25. So there were 4 experts, right? The 4 experts were radiology teachers at prominent universities that teach dentists how to.
That's what I'm
Yes.
asking. So radiologists, so
Yes.
the interpretation of a radiologist versus the interpretation of a dentist or anybody else is going to be vastly different.
So they were professors at dental schools who are board certified dentists that teach students how to read radiographs. I don't exactly know if radiologists, yes, I don't know. And so then the readers themselves were, I know they were just normal dentists. Cool. Last thing, I mentioned in the beginning ChatGPT and how it's fundamentally different. What ChatGPT does and what's kind of really cool about the way that technology works is that it has global context in a way that the CNNs that we've been talking about here don't. The fundamental huge difference is that they need, as you guys might read in the news all the time, they need absurd amounts of data in order to be really, really good. But once you get them significant amount of data, they're exceptional because they can run a lot more in parallel and they have the full, so they'll be able to see the full image in the way that a CNN can't. And so the future most likely will be, the technology that ChatGPT uses is something called a transformer. The emerging technology is called a vision transformer, which is transformers for images. So my bet is that in the next 10 years, all of this will switch to vision transformers because they have full context, and a lot of the drawbacks and stuff that I talked about probably will start to go away.
Thank you, Hamza. Thank you so much.
Yeah.
Thank you again, Hamza, for speaking on that. Their next lecture is at